Welcome to the VHQC Move-In Sharing Call. All lines have been placed on listen-only mode, and the floor will be open for your questions or comments following the presentation. We've actually placed it into interactive mode today. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Deb Smith. Ms. Smith, the floor is yours.
Good afternoon, everybody. This is Deb Smith, one of the improvement consultants for VHQC, working on the HAI improvement work. And I want to welcome everybody to the call this afternoon. I also want to share with everybody that I am doing this kind of blind today because I'm having technical difficulties pulling up the webinar, but hopefully nobody else is, and we're all here on the call and ready to go. You will see that there's a polling question that's been up. I hope everybody's answered it, and once the polling question closes, we'll be able to let you know who's on the call today. I would also like to go over the sharing call etiquette. This is what we go over every single month on these calls, but please be present and attentive. Your lines are all open. So be really cognizant to keep your line muted when you are not talking. They're open so that we can have a sharing environment and be able to talk back and forth. Of course, if you do have to take a phone call or leave the office, just hang up and call back in. Come prepared to share any of your patient-family engagement, lessons learned, successes, barriers, articles, research, anything that you'd like to share that would make infection prevention and decreasing HAIs easier. So I'd also like to welcome on the call today, we have the Virginia Department of Health, of course, Andrea Alvarez, Sarah Lineberger. They'll be doing one of the presentations. The Maryland Healthcare Commission, Eileen Witherspoon and Evanson McCura. They'll be doing another presentation. We have all of you, the Maryland and Virginia providers, and we've got stakeholders in Maryland and Virginia on the call. From the VHQC team, we have Carol Whalen, Improvement Consultant for Maryland, and myself, the Improvement Consultant for Virginia. Rhonda Fletcher is listening on the line, too, because she'll be taking care of any of our technical difficulties during the call. So this is our call.
Deb, I just wanted to jump in there and say hello to everyone from my side. I'm the one advancing the slides today, guys, so cut me a little slack today.
I'm assuming they're going through just fine, right?
So far, so good, Deb.
Okay. Well, this is our call, our sharing call. Participation from everyone is encouraged. We do have a chat monitor today. And Patty, do you want to introduce yourself? She has volunteered to be our chat monitor, so thank you very much, Patty.
I'm Patty Hall from Medstore St. Mary's.
Thank you. You're doing an awesome job. We did not get a time monitor, so is there anybody out there that would like to monitor our time? The time is actually on the sharing call agenda just to keep us moving and make sure that we don't run out of time. Do we have a volunteer? Come on, somebody volunteer. We'll have to volunteer somebody. All right. Well, we will try to get that the next time. It's really not hard. It's just somebody to keep the call going.
Deb, this is Jan Mandan. I'm having to help be the timekeeper. So what is it exactly you'd like for me to do?
Oh, thank you, Jan. Just keep us moving as we get, into something where we need to move on. The times are actually on that agenda that was sent out.
Okay, all right. I will follow along with that and let you know when we need to move on. Okay?
So right now we need to move on because I am 2 minutes over my time.
Okay.
So I would like to, at this point, introduce the Virginia Department of Health, who will be doing a review of the 2015 CLABSI data in Virginia adult ICUs. And I will let them further introduce themselves, but it's Andrea Alvarez, who's the HAI Influenza Program Coordinator for the VDH, and Sarah Lineberger, who is the epidemiologist, HAI epidemiologist for VDH. So, ladies, the floor is yours.
Thanks, Deb. Guys, this is Sarah. Let me interrupt just a minute. I'm thinking we're supposed to have some polling questions before the presentation. Is that right, Deb?
Oh, I see that. Yes, I'm sorry.
So
Emily, did you put the polling question up for number 2? And they can answer that while the presentation is going on.
Yeah, so just make sure your polling tab is open, and when Emily posts those questions, go ahead and answer those during the presentation. I apologize, ladies. It's all yours now. Thank you.
Great. So this is Andrea Alvarez. I just want to say hello to everyone and turn the floor immediately over to Sarah Lineberger, our healthcare associated infections epidemiologist. She had noticed an increase in our CLABSI and adult ICU data starting in 2016, and so we took a deeper dive into the data, and Sarah is going to talk about some of those specifics. Okay, great. So the Virginia Department of Health, just as a little bit of a background, has been receiving CLABSI data from adult ICUs through NHSN since 2008, since July of 2008. And as many of you know, new reporting regulations took effect in September of this year, and those align state reporting requirements with what is required by CMS for their hospital and patient quality reporting programs. And so VDH will now be receiving data for CLABSIs, CAUTIs, SSIs following abdominal hysterectomy and colon procedures, MRSA and C. diff lab ID events, as well as healthcare personnel influenza vaccination data. And so we've been working to have hospitals reconfirm rights to our department so that we have access to all of that data. Okay, so the standardized infection ratio, or SIR, for CLABSIs, as Andrea mentioned, increased in 2015 quarter 1, and again increased in quarter 2 of this year, as you can see by the red line on this graph. And this is the first time since quarter 3 of 2013 that there's been an SIR over 0.5 for CLABSIs in Virginia. Next slide. It was noted that there was a large decrease in the number of central line days in the state from 2015 quarter 1 to quarter 2, and you can see that by the blue line on this graph. And so we were wondering, could the number of central line days be affecting the CLABSI SIR? And as you know, SIR is observed infections over expected infections, and the expected number takes into account the central line days. Therefore, the number of central line days directly impacts the SIR calculation. So we examined the changes in central line days from quarter 1 to quarter 2 by facility in Virginia, and there were a handful of facilities, about 6, with a central line day decrease from quarter 1 to quarter 2 between about 200 and 300 days. But those were the most significant. And most of the other facilities only had small changes in central line days. We then also looked at overall patient days from quarter 1 to quarter 2, and there was a little bit of a decrease, as you can see by the green line. But it was only a slight decrease in patient days, and so we don't think the large decrease in central line days was explained by the change in number of patient days. Next slide. Okay, to further examine the increase in CLABSIs, all CLABSIs from the last couple years were grouped into the following categories based on primary pathogen only: gram-negative bacteria, gram-positive bacteria, yeast, or cannabis species, and then finally gut translocator. And you can see the organism specified below gut translocator. This category includes bacteria and fungi that could have moved from the GI system across the intestinal membrane and into the bloodstream. Thus, the thinking is these CLABSIs could be the result of gut-derived organisms that did not originate in the bloodstream. And these categories are not exclusive. Next slide. So the 4 categories are broken out here for CLABSIs And in the background, the blue bars in the background are the total CLABSIs for each quarter. Infections due to yeast have gone up and down, but generally up in the past year, as indicated by the red line on the graph. And infections from organisms classified as gut translocators have also increased, as you can see by the red line on the graph, or the orange line on the graph. And we're going to look more closely at the orange gut translocator line on the next slide. Here you can see CLABSIs being attributed to gut translocating organisms, the orange line, compared to total number of CLABSIs by quarter, and those are the blue bars. If you look at the increase in CLABSIs in the first quarter of this year, this graph seems to imply that it could have been due to an increase in CLABSIs that were the result of gut translocating organisms. Next slide. In this graph, it looks a little complicated, but basically we just took out CLABSIs attributed to yeast out of both the number of infections, so the bar graph, and the quarterly SIR, or the line graph. In 2015, in January of this year, there were NHSN definition changes affecting CAUTI and therefore affecting CLABSIs. And so we had some discussion about this in our Virginia ATI advisory group, and we wanted to bring this up again. For CAUTIs, in 2015, fungi, those yeast and molds, those were included in previous CAUTI surveillance definitions, but were clinically determined to be due to colonization, not true clinical UTIs. And so the thinking that was in the past, CAUTI numbers were inflated in order to increase specificity and make CAUTI data more reflective of prevention successes or failures. For 2015, only bacteria are accepted as the causative organisms for UTIs. And so fungal organisms alone no longer meet the infection criteria for UTIs. In addition, these excluded organisms cannot be assigned as secondary bloodstream infection pathogens for UTIs. And so fungi must be attributed as a secondary bloodstream infection to another primary specific site or identified as a primary BSI. And so the thinking is the fungi, the change in the CAUTI definition with fungi could again point to yeast infections as a contributing factor in the 2015 CLABSI increase if those fungal infections are being attributed to bloodstream infections and not to UTIs. However, looking at this graph in front of you, one point that we want to stress is that there is still an increase in the CLABSI SIR in 2015, whether you look at the data with or without yeast. So whether you look at the blue line or the red line, there's still an increase. And so the red line on the graph, the SIR without yeast is still increasing. So it seems like in addition to the change in definition, there might be something else going on contributing to an increase in CLABSIs. Next slide. And so this slide just summarizes some of our thoughts around the CLABSI data. First of all, many facilities are experiencing CLABSIs. It's not just an issue in one or two hospitals. CLABSIs are occurring in all types of ICUs, although we are seeing a higher percentage in medical surgical ICUs compared to other types of ICUs. There are more hospitals experiencing one or more infections compared to prior quarters. So in quarter 4 of last year, there were 11 hospitals with one or more CLABSIs. In quarter 1 of this year, that was up to 23 hospitals with one or more CLABSIs. And that dropped slightly in quarter 2 of 2015 to 16 hospitals with one or more CLABSIs. As discussed, infections due to yeast pathogens and gut translocator pathogens have increased this year. We're also seeing increases in CLABSIs due to Staphylococcus aureus in quarter 2 of this year. And so we could have more discussion around that pathogen. As shown, there were fewer central line days in 2015 quarter 2, and so we've considered several different ideas. One being whether or not there were fewer patients, and as we showed, the number of patient days did not change significantly from quarter 1 to quarter 2. The idea has also been brought up that maybe central lines weren't inserted in the first place, and so maybe some facilities are inserting more midlines instead of central lines, or maybe central lines are being taken off policy. Finally, we think some attention is needed to central line maintenance practices because on average, there are about 19 to 20 days between admission and CLABSI. And so at this time, we'll take questions, and then I'm sure they also want to go back to the polling.
We haven't done that since we started, got that new machine, so anyway.
And we can
Everybody,
put it background noise. Go ahead, Bob.
there's somebody who is not on mute, so please take the time to get yourselves on mute. Thank you. Yes, we should go back to the polling question if that wasn't done. Thank you. There. Emily from WebEx, could you put that polling question up, please? There we go. Thank you. And if everybody could just take the time to answer that, because we're curious who's had an increase. If you've had any CLABSIs this year, is that an increase from 2014? So we can move on with questions then. I'm sorry. Thank you. I'm going to hand this back to Sarah. Now you can unmute your line and ask questions, or you can type them into chat. So it looks like from the people who have answered, 13 of 43 have seen CLABSIs this year, and about half of them are saying that it was an increase. So it looks like most people are not seeing CLABSIs. There's 26 that didn't answer, but that the ones that are seeing CLABSIs, this is not really an increase over 2014. So that's good to know. Thank you. And Sarah, do you have a couple more slides to show then?
We do have some supplemental slides, but it might be good to have Marilyn give their presentation, and we can always come back to questions or go through slides if there are specific things that people want to talk about more.
Okay, well, that's what we'll do. We'll go on to the Maryland Healthcare Commission, and if there's time, we can go back to those slides also, those supplemental slides. So thank you very much, Andrea and Sarah. I appreciate that, and hopefully we get some discussion after we hear all of the presentations. So right now, I'd like to turn this over to Eileen and Evanson from the Maryland Healthcare Commission. Eileen Witherspoon is a health policy analyst, and Evanson McCurry, I'm going to let him tell us what his name is, and is the program manager for the Maryland Healthcare Commission. So the floor is yours.
Thanks, Deb. This is Eileen, and that was some great information from Virginia. So I just wanted to thank you for inviting us to speak today. We are from the Center of Quality Measurement and Reporting at the Maryland Healthcare Commission, which is a regulatory agency for the state within DHMH. And we're going to be talking about CLABSI in Maryland hospitals. You can move to the next slide. We will briefly go over the history of HAI reporting in Maryland and then show CLABSI trends in Maryland acute care hospitals. Lastly, we'll touch on the future of HAI reporting in our state. You can go to the next slide. So I won't go through each of these lines, but this is a timeline of HAI reporting requirements for acute care hospitals in Maryland that began in 2008. So prior to Maryland aligning with 2014, the state, with the guidance of MVHCC's HAI Advisory Committee, determined which HAIs hospitals were required to report. So in 2014, Maryland aligned with CMS's value-based purchasing program requirements. You can go to the next slide. So this slide has a lot of information on it, but it shows trends in CLABSI in Maryland hospitals from calendar year 2010 to calendar year 2014. So Maryland hospitals have decreased all ICU CLABSIs by over 50% between 2010 and 2014. Central line days have also decreased. In the past 3 years, total CLABSIs have remained around 180 each year. The NICUs have also improved about 30% in 2014 compared to 2010 numbers. No hospitals have done worse than the national experience since 2011. Maryland hospitals have done a great job of lowering the number of CLABSIs since reporting began, and the SIR for the state has decreased from over 1 in 2010 to 0.5 in 2014. So you can move to the next slide. So VHQC had asked that we focus on the first 2 quarters of calendar year 2014 and calendar year 2015. We usually report data on an annual basis, but trending the data by quarters gave us some interesting information. So as you can see, CLABSIs, which is the dark blue line that starts at the top, decreased by almost 50% in quarter 4 of 2014 compared to quarter 3 of 2014. But the overall trend line, which is the middle light blue line on the graph from quarter 1 2014 to quarter 2 2015, shows that Maryland hospitals as a whole are averaging about 40 or so CLABSI infections each quarter. So we hope to look more closely into the Q4 2014 data to see if anything or any hospitals stand out. But it would be great if that could become the norm for the state. As you can see, the central line days, which is the bottom red line, remains steady throughout the time period. So that doesn't explain that dip that we're seeing in that 1 quarter. And it was great, the detailed information Virginia gave. So we could look into some of that information on our end as well. Moving to the next slide. As we mentioned, MHCC's reporting requirements have been expanded as of 2014 to be consistent with CMS VDT reporting requirements. We also support HSCRC and the Quality-Based Reimbursement Program, which currently uses CLABSI, SSI, and CAUTI data in their performance measurement. I also wanted to mention that we completed a data review and validation process with our contractors that began in the spring, and we'll be holding a webinar for the hospitals and sending out final reports to the hospitals in early November. And we also just wanted to mention our public reporting website, healthcarequality.mhcc.maryland.gov. And that's going to be updated this month with CAUTI and MRSA calendar 2014 data. And then you can go to the next slide. We can take any questions if anybody has anything. And we're just wanted to say thanks for the continued efforts that the hospitals have been doing with HAI reporting. So thank you.
So does anybody have any questions for Eileen? That is really interesting data when you look at it between the 2 states. We were wondering if we were going to see trends that were similar, but at this point it appears to be more just Virginia. However, we did want to also show VHQC's data, keeping in mind that this is not statewide. These are the VHQC HAI network providers. So the 36 in Virginia and the 28 in Maryland. And what we're showing here is somewhat similar for the first quarter of 2015. There was a spike in CLABSIs in the ICU, and so as you can see here, it's the Virginia Hospital ICU units with CLABSI. And pretty much we should have put a trend line on here, but we didn't. But it does look like it is trending down if you consider that the first quarter of 2014 was 0.64, and we're now second quarter of 2015 at 0.3. Where we finished up that note on the bottom, the 10th scope of work, which was our last contract work that ended in July of 2014, we finished with those hospitals at 0.365. So you can go on to the next slide. And this is Maryland, and these are just the providers that have been recruited by VHQC for the network. So we're actually showing something a little more similar with the network to what Virginia was seeing, just with these network providers, and that's 28 of our network providers, where you can see it started out at 0.3. It has definitely increased. The SIR has increased, and the number of CLABSIs have increased for those 28 Maryland hospitals. Any questions or comments about this? Is there anything in chat?
No, there's nothing in chat.
Thank you, Patty. All right, let's move on to the next slide. Now, we're also going to show the CAUTI slides here. There was some discussion. There's a Virginia HAI advisory group that meets quarterly, and there is a data subgroup, but there's also education, readmissions, there's antimicrobial stewardship. There's many stakeholders involved in this meeting across the state of Virginia. So the discussion started going on about the difference in the definitions beginning in January of 2015, and especially with some of the yeast that we were seeing. So the question is, do we think that there's any impact that these definitions have on the CLABSI rate, since we can no longer call yeast as a CAUTI? It's been taken out of the definition as a pathogen, as has a couple other bacteria. So now any of those bloodstream infections that were attributed to yeast from urine would have been secondary and now are being called primary CLABSI. So as you can see here, at the same time that our CLABSIs were increasing, the CAUTIs actually did decrease. So that high quarter, 2015, for CLABSI is actually the lowest quarter for CAUTI. And if you go on to the next slide, it is, here's Maryland. And Maryland is showing that same decrease, but theirs is even more evident, starting in quarter one of 2015. I believe the next slide is a polling question. So here again, we'd like to see, is your facility, have you had any CAUTIs this year? And is that a decrease from last year? And then while you're answering that, we really would like to get some discussion going to see if there's anyone out there that feels that this might be a contributing factor.
You know, Deb, while everybody's answering the polling questions, you and I spent some time discussing this data and looking at this data. And I'm just curious, when the folks on the call, as you look at this data and you think about what's going on inside your hospital, you know, what are your thoughts as this data compares to what's going on inside your hospital? Be thinking about, you know, the conversations you've had with your teams and with your leadership about these numbers, and we'd love to hear you know, what's going on within your organization as you guys look at this data.
Sorry, I'm on mute. This is Deb again. We do have some in the open forum, we have some questions to kind of get this discussion going. But we have the next 20 minutes set aside to talk about some of the reasons why this could be happening and to share with each other what we've been doing in the hospitals to decrease CLABSI, or if you've had to change any of your policies or protocols this year to address any increase that you're seeing. So, as you can see here with the polling question, 17 out of 43 that answered, 17 of the people that answered, do have CAUTIs this year, but they're not seeing a decrease. There's only, oh yes, they are. I'm sorry, I'm reading this incorrectly. So 11 of those 17 have seen a decrease, so it appears that, of course, you all are following along with the trend of the network because you're all part of the network. So what do we think that reason is?
Remember to unmute your phone, and or you can type into the chat box. So this is Patty. Yeah, go ahead, Patty.
So with part of getting the CAUTI implemented, that last year we actually had 9 CAUTIs that we had. That was ICU and non-ICU total. When I look at everything this year, so far we've had 0. That's been more from the nurse-driven protocol, and with the education that's going out to really and truly address every indwelling Foley that is in place daily.
Well, congratulations. That's remarkable. So the fact that the definitions change actually didn't really impact your numbers that much. They have some, but your focus remained on the quality of care that was given. So that's remarkable. Right. We're still having a little bit of background noise, so remember, if you're not speaking, to go ahead and mute your phone. So is there anybody else on the call today that has seen that the definition change has remarkably reduced their number of CAUTIs or CLABSIs in effect of CLABSI? So maybe we've got some folks that this is the first time they've actually seen this data, seen these data numbers, and maybe, we have some folks that are still scrambling and looking at their data in comparison, and that's understandable.
Hi, this is Evanson from Maryland Healthcare Commission.
Sure. Hi, Evanson.
Hi. This the first time that we are publicly reporting the CAUTI data, and we are doing calendar year 2014, and there was a lot of number of events for 2014. In total, we had about 601 events for all the hospitals in Maryland. And I've been trying to look at the data for the calendar year 2015, and that number has reduced for the couple of months that have been reported. And I've reached out to a couple of hospitals that had a lot of events, and one of the things that everybody is in agreement is the change of definition has totally reduced the number of the events that have been reported. And I know all these hospitals also have protocols, changing protocols to help them reduce the number of CAUTIs. So there is a huge improvement. But most of it is can be attributed to the change of definition.
And then the next question is that change in definitions driving up the CLABSI rate? Is there any possibility that could be one of the contributing factors to increase CLABSI?
I cannot look, so far we have not seen an increase in CLABSI because we see about 40 in each quarter, so there is no significant change as far as the total number of CLABSI in our state.
Right, we've seen that, yes.
Right.
Hi, this is Stephanie from CAUTI in Baltimore.
Hi, Stephanie.
And our biggest issue with the ICU, we had about 50% of our isolates urine isolates in the ICU last year being yeast attributable. So the change in definition obviously just immediately cut in half our CAUTI rate. We were doing a lot of work also around best practices, so that's helping to drive it even further. But we did also notice an uptake in CLABSIs with yeast organisms, but when we did the deep dive, we could not link it to infections that we would have called secondary to urine. We found more that these patients had known maybe esophagitis with Canada, maybe would have been great candidates for possible prophylaxis, fungal prophylaxis, because of their long ICU stays or GI surgery. So that's something the medical team and the ICU team is looking into and doing literature searches to see if maybe we might have missed an opportunity to prophy some of those higher risks. The literature is kind of, there's not a lot of great literature to support it one way or the other, but there's some. So they're looking to have a grand round session, et cetera, on exploring that literature.
That's interesting. And it's interesting you did the deep dive because, on the surface you would maybe think that that's why your CLABSI increased. So it's more gut translocation is what you're attributing it to.
Yeah, gut or some other secondary thing that we weren't able to attribute directly to a definition.
Mm-hmm. We'd be interested in hearing your grand rounds. What comes out of that, that would probably be something that the rest of us would enjoy hearing.
Sure, there's a speaker at the NIH who are trying to get in who's a fungal expert, and when that's scheduled and we have that, I'm happy to share.
Thank you.
Thank you, Stephanie, for sharing that. I'm just curious if there's anyone else on the call today who may have implemented some best practice around prophylaxis in this area that they'd like to share. Sometimes we have some folks that are trying new things, and so we'd like to hear from you if you are in this area. Doesn't sound like a whole lot's going on there, Stephanie. So you guys may be leading the pack on that emerging evidence. So we'll be excited to hear back.
So do we have any more comments from VDH, possibly about how any of this ties back in with the data that you've been seeing, or do you have any questions that you specifically would like to ask the IPs on the line?
Sure. I mean, we were wondering if anyone has had significant changes in their central line insertion practices. We were really excited that we were seeing that downward trend. We're seeing lots of improvement. And so we're wondering if there were changes in insertion practices or maintenance practices, how getting the catheter out in the facility has driven down the central line days, which is great. But just wondering more from a process standpoint, if there are any systematic changes in place in your facilities over the last couple quarters.
Hi, this is Deborah from Martinsville.
Hi, Deborah.
I was just able to join the call because I was in another meeting, but I can say that here at Martinsville, we've had the exciting thing happen this year where we've not had one single CLABSI. And we attribute a lot of we've always had the bundle, we've got the kit, the central insertion line kit together. We have a lot of things that have been in place for a long time, and they reduced, but we couldn't eliminate. And the only thing that we've done differently this year that we haven't done in years past is that we've added alcohol caps. That's the ones that you screw on and stay on. Instead of the scrub the hub, we have alcohol caps that stay on all the time. I mean, there still are times when you've got to scrub the hub, but, I mean, we keep the pigtails that are flopping into the patient's gown or whatever are covered by alcohol.
And you're not the first hospital that I've heard has done that. Congratulations to you. Is there any other providers out there who have done the same thing and seen progress, seen positive results? How many are using those alcohol caps?
So let's pose it as a question in the chat box. So if you're currently using alcohol swab caps, just comment in the chat box yes, why for yes, and 10 for no. So we'll get some activity going on there. You know, in doing our one-to-ones this month, I spoke with a lot of IPs about what was going on with CLABSI, and unlike Deb, the folks that had really made some remarkable reductions in their CLABSI rates were using the alcohol cap. So I'm glad you brought that up, Deb. Thanks for sharing that.
Can't get into the chat box, but just include me in the mix.
Sure will.
And it's interesting because you did also bring up the central line insertion practice bundle. I mean, that's something that we put on here in the open forum. We're assuming everybody's still using that bundle and that, you know, everyone has an insertion line kit. But did you have to change any products recently? If you're seeing a CLABSI, I mean, due to cost and economics or for whatever reason, did you have to change a product within that kit? It would be really nice to know that also. Anybody want to talk up about that? And Teresa Burton, I mean, since you've been using the swab cap since the end of 2011, yeah, that's a while now. When you started using it, Teresa, did you see a big decrease in CLABSIs?
Actually, we did. We've trended down quite a bit. We have not had a CLABSI, and I knock on wood.
I am too for you.
2014, the very beginning of 2014, the end of 2013, hospital-wide.
Wonderful.
But we've instituted so many things. I mean, we changed our balance checklist, the swab caps, the stat locks, just everything. And we bundled everything on the floors together for easy access for the nursing. We packaged line, the central line changes all in one bundle. The nurse could just pick up instead of picking up a 2x2 here and a swab here or something like that. So we bundled all of their care supplies for compliance, to increase compliance. And also last year, PIC team has now taken care of all the central lines hospital-wide.
So you have a PIC team who goes out and does all the care and maintenance?
Yes, they were doing ICU for about a year, but because of the FTEs needed to increase that, because we were doing so many central lines, PICs, jacks, and all these other lines, they weren't able to do it until last year. So now they're doing hospital-wide central line care. And nurses make a card for every patient who has a central line that comes in, whether it's our central line or a central line that's placed on the outside. And so they take a look at the line to make sure that it has all of our hospital protocol, for compliance.
And is that on admission? Like, so if somebody comes in with a central line already in place, your PIC team does that too?
Yes, it's in Cerner, and my understanding is the nurse will say the patient came in with a central line, and so it will automatically send a message to the PIC team to let them know that this is a central line that they may have placed or a central line that came from another facility. They won't know until they go and actually look at it, or unless they actually recognize the patient. Because they'll look up their card first. I'm sure that's how they do it. But anyway, the only floor that has assumed responsibility for their lines is our surgical floor. That nurse manager has her nurses take care of all their central lines. They rarely call the PIC team for help.
And you're not seeing CLABSIs there either?
No, hospital-wide, no CLABSIs. CAUTIs we had a blip in, and we've had to institute quite a few meetings I've had to address this, and some of it was we're trying to get the hospital, the staff had, I don't know, sometimes, you know, you work on a process, and what happens is we do well, and then we move to something else, and then the compliance issues raise their ugly head again.
Yeah.
So what we were finding is that catheters were not, when they came into the facility, they weren't getting their costs in a timely manner. So they could have prevented being possibly our infection, but we had to own it because we didn't culture the catheter. I mean, we didn't culture the urine specimen. And the patient developed criteria that met the definition criteria. And then also we're initiating the nurse-driven protocol.
To remove?
Yes. I brought that to internal med 2 years ago, and it got turned down. It was initiated in the ICU, but we came with the algorithm and everything, but now have 2 champion physicians that are going to present it with me in internal med in December. So
well, good. I hope you also let us know how that goes.
Yeah, and, you know, it's needed to come for quite some time, and corporate is supporting it, too, so there's a lot of...
Yes, this is Jan. I didn't want to interrupt this Teresa's wonderful discussion about what they're doing at her facility, but you have 10 minutes left in the hour.
All right. I think we're going to spend a little bit more time on this, and then because I'm curious if anybody else has been doing the same thing as Teresa's been doing in her hospital. Is there? I'm wondering how many hospitals out there do have a PIC team that can take care and do care and maintenance.
Yeah, I responded to them.
And there is somebody who has their line unmuted that's talking in their office. If you could mute your line, that would be really nice. Thank you. So is there any other hospitals out there that have PIC teams?
So if you have a PIC team, why don't you put yes in the chat box? And Deb, I just want to address a couple of the no's, the people who do not have the alcohol swab cap. Some of them express that it's due to cost, and I think that, you know, if you can show if you're having CLABSI and you're just not able to get the cap, then we could probably help you show the cost through a cost calculator of what the infections are actually costing your hospital compared to what it would cost to supply the cap. So if you're one of those folks, so that's one of the reasons you're not using it, contact either Deb or I, and we'll be happy to help you identify, you know, what those cost differences would be. So that's one of the reasons we're here.
This is Teresa from Southside. Those caps, it took me quite some time to get the CFO to approve that with evidence-based research and cost analysis with CLABSI. So was a struggle, but we finally got it. I just didn't give up.
Good. And I like the way that you didn't give up on your protocol either, because we've been doing this. We've had an intense focus on HAI reduction for a number of years now nationally, and we're still struggling nationally with getting this. So, and what we found is that early on it has been a difficult challenge to get these nurse-driven protocols in place, whatever those look like within your institution, whether they're truly nurse-driven or if they're just nurse alerts and to seek that physician order, whatever it looks like. If you tried before and you can't do it, try again. Some time has passed by. There's been a lot of information out there with the professional organizations. So I'd say give it another try. Give it another round of try, getting those nurse-driven protocols in place.
All right. Well, I really appreciate everybody who's shared today. We're going to move on with our agenda because we do have some stakeholders on the line who may want to give a couple updates. And any of this, I'm sure, well, I'm not sure, I'm going to put Teresa in the spotlight again, but Teresa, would you mind if people contacted you to just chat a little more about how you got those slabs in place? Maybe you have a couple tricks or something you can help them with?
By all means.
Awesome. So if anybody that needs Teresa's contact information, just let us know, and you can have a chat with her. So if we go further in the slides here, we'll see the stakeholder updates. And we can just go down this list, and then if there's any other stakeholders who I don't have mentioned here, we can have that too. So Virginia Department of Health, do you have any updates?
Nothing else to add. Thanks, Deb.
Thank you so much, ladies, for your presentation. That's very interesting.
You're welcome.
Virginia APIC? Is there anybody on from Virginia APIC? We are having the Virginia APIC conference this week. Thursday is a CIC review day, and Friday is the all-day conference. So I hope everybody's signed up and going.
Hey, Deb, this is Betsy.
There. Hi, Betsy.
Also, remind you that next week is International Infection Prevention Week.
Oh, thank you.
Yeah.
Yay. Happy and
Yeah.
to everybody.
Thanks for mentioning that, Betsy.
I guess all your leaders are taking you all out to lunch, correct?
I thought we were going to a 5-star hotel.
Oh, good. Yay. All right. Anything else from APIC, Betsy?
No, not other than the conference.
Okay.
Guys, is it too late to register for the conference?
No, not at all.
Okay. All right.
You can do it online. Or do you know
Right. Yeah. Just anybody that still wants to register late, just drop me an email and I'll send you the link.
Thanks, Deb.
Thank you. So VHHA, Jan, I know you're on. Thank you for being our timekeeper.
You are most welcome. The biggest news for us is that we finally received word from CMS through HRET that the funding for the second round of the HIN Hospital Engagement Network is a go. So that came in on the 24th of September. So the clock is now running, as this is just a 12-month campaign this time instead of the 3 years that we had that began in 2012. So we are in the process now of receiving commitment letters from our hospitals that have initially expressed interest in joining our HIN again. And we will again be focusing on the same HAIs that we did in the first round, but we also have some other optional topics. So sepsis and C. difficile will be part of our work this next 12 months.
Well, congratulations, and we look forward to partnering with you again.
Terrific.
MHA? Is there anyone on from Maryland Hospital Association? Maryland Healthcare Cost Commission, thank you very much for presenting today. Is there anything else you want to update us on?
Thanks for having us, though. I didn't have anything else. Evan said, I don't know if you did.
I have a question, Eileen. Will you guys be sending out, will you be doing your update for the Maryland hospitals early in November? Will that be a webinar? Will that be an invitation only? How are you guys rolling that out?
Yes, it's gonna be for the hospitals, but we can definitely include you if you guys are interested in listening. But yeah, it'll be a webinar. We're hoping for early November. So yeah.
Great, thanks.
Yep.
And the Maryland Department of Health and Mental Hygiene, did I say that right? Is there anyone on from that? Or Maryland Patient Safety Center? All right, well, I'm going to turn the rest of this over for Carol. We just have a quick couple announcements, and then don't forget to fill out your survey at the end of this just to let us know how things are going and if you want to change anything with this sharing call. So, Carol, the floor is yours.
Okay, well, guys, thanks for responding in the chat box today on the questions about the teens and about the alcohol swab caps. And we wanted to give something back to you and provide you with some feedback data. So we've really been working with our hospitals to get the data in by the 30-day after the end of the month. And the purpose of that is so that we can, when we have our quarterly data calls and we have our ability to look at our ranking within our network. Everybody's got their data in, and we have a good, solid ranking on that, and it becomes very valuable data to all of us. So we thank those of you that have your processes in to get that data in, and we wanted to show you our progress with the July and the August data submission compliance. So, of course, our goal is 100%. Of course it is. So if you're struggling in any of those areas and you need assistance or any clarification, we're happy to help you with that. So we are at the top of the hour. Don't forget our resources that are available on the online community. If you haven't signed up, please do that. We look forward to talking to you individually between our calls, and we appreciate your feedback, letting us know what you're interested in so that we can customize the calls for you. Our November meeting, we'll be doing our quarterly update, a case review, and we're seeking volunteers for our chat monitor. Thank you, Patty, again for doing that. It wasn't too hard, was it?
Not at all. You're most welcome.
Okay. Thank you guys for doing that for us. We appreciate it, and have a good week, a good day, and a good week. Anything else, Deb?
No, just thanks to everybody. Great presentations, good sharing. I always really appreciate that on these calls, and I look forward to them and enjoy them. So you all have a wonderful rest of your day, and we'll be talking to you soon.
Bye now.
Again.